Welcome back. Today we'll be discussing Chapter 23, which covers behavioral and psychiatric emergencies as well as suicide. So this is a topic that has been gaining a lot more of our attention as EMS providers. When I first started my career, this was a little more few and far between, and now it's a very routine call for us to go on. So this, I imagine, is probably going to become more and more relevant. So unfortunately, I'm only going to be covering the basics of behavioral and psychiatric emergencies, but you should really study on your own and try to find out some more information about some of these diseases that we will be discussing, because this is turning into a very big part of what we do as EMS providers, is dealing with behavioral and psychiatric emergencies as well as suicide. So this is just going to cover some of the basics, and it is very important that you kind of branch out beyond just the textbook and beyond what I'm going to present in this short lecture, and do some research on your own. All right, so we're first going to talk about some of the different behavioral and psychiatric emergencies that we will see, as well as some of the diagnoses that might cause some of these emergencies. So, behavioral emergencies. That's where a patient is presenting with some sort of unexpected or dangerous behavior. It's either dangerous to them or dangerous to others. Either way, we treat it relatively the same. These are patients that won't be able to refuse care from us because they are being a harm to themselves or others, and we'll talk about that a little bit later on in this chapter. It can be caused by many different things. Stress can cause it, some sort of physical trauma or illness, anything that would normally cause altered mentation will cause unexpected or dangerous behavior. Drug or alcohol abuse can do this, and diagnosed psychiatric conditions can do this. It is important to know, though, that you can have a behavioral emergency without having a diagnosed psychiatric condition or any other medical emergency, such as like an altered mentation type emergency. This is something that can happen to anyone at any time, just when they're experiencing stress. That's why we emphasized dealing with stress so early on in this course, because the second chapter was talking about how we can deal with stress, because that can even affect us and cause us to have a behavioral or psychiatric emergency. So some terms that we should cover early on. Behavior is the manner in which a person acts or performs. Then a behavioral emergency is when the behavior is not acceptable to either themselves, us, the community, their family. So it's unacceptable to the general public or to themselves. So those are two terms that we should keep in mind when we're talking about behavior and behavioral emergencies. So, behavioral emergencies may appear confused and have altered mental status. That's where it becomes very hard for us as EMS providers to try to differentiate, is this being caused by a psychiatric condition, or is this being caused by some sort of medical emergency causing altered mentation? Sometimes it could be caused by both. So it kind of makes it hard for us to do our jobs fully, because it's hard for us to differentiate with the limited assessment tools that we have in the field between what is what. So that's why we always have to treat to the worst possible case and hope for the best possible case, but we always have to treat for the worst possible case out there. So we're going to talk about 4 major psychiatric conditions. Again, this is not a comprehensive list. This is just some of the more common ones that we're going to see in our careers as EMS providers. So first one we'll talk about is anxiety or panic disorder. Next one will be depression. Then we'll talk about bipolar disorder. Then we'll talk a little bit about schizophrenia. So anxiety is a very common diagnosis. It's becoming more and more common as time goes on. I think one of the last statistics I read, and don't quote me on this, and it probably has changed already, is that 1 out of 3 people at some point in their life is going to be diagnosed with anxiety. So it's very common. Typically, anxiety is either controlled by yourself, so you just self-manage it. When you have some sort of panic attack, you can deal with it yourself, or it's controlled with home medications, and that usually controls anxiety pretty well for most patients. Anxiety can lead to acute panic attacks. That is typically when we get involved as EMS providers, is when someone has an acute panic attack. So panic attacks present themselves with hyperventilation, which causes a lot of problems in the body. The main issue with hyperventilation is we actually breathe off too much carbon dioxide, and your body likes a certain amount of carbon dioxide in it. So when we are hyperventilating, we're exhaling way more than we should. We're breathing all that carbon dioxide off, and that's going to change our acid-base balance in our body. When your acid-base balance changes, your brain does not like that. So it's going to start to send signals to make you stop doing what you're doing. So that's why when you breathe very fast, you're going to get lightheaded and dizzy. That's your brain telling you, stop this behavior. We need to reset because the blood chemistry is starting to change. If you continue to hyperventilate after these warning signs are given out, your brain can just say, game over, we're shutting down, and make you lose consciousness. Typically, someone's having a panic attack that is causing this hyperventilation. Once they lose consciousness and they can't consciously control their hyperventilation anymore, their breathing immediately returns back to normal. So that is kind of the worst possible scenario for a panic attack, is losing consciousness. When patients don't lose consciousness, some other signs that you might see is a pins and needles feeling in your fingers and in your toes, like your far down extremities. That's called paresthesia. It's something I can never pronounce. It's right here in the slides. That is the medical term for the pins and needles feeling, as well as some uncontrollable hand jerking around. So like you won't be able to really close your hand very well. It's going to kind of be shaking, and that really does scare a lot of people, especially if it's the first time that they're feeling this. And that's a result of having too little carbon dioxide in your bloodstream. So unfortunately, the only real treatment that we can provide people having panic attacks is coached breathing. So this is where we can try to have them take a long inhale, hold it, exhale, and then take a pause. So usually at 4 seconds for each event is a good way to try to slow someone's breathing down. So you inhale for 4 seconds, hold for 4 seconds, exhale for 4 seconds, rest for 4 seconds. You might have to start with 1 second or 2 seconds and then work your way up, but that's a good way that you can hopefully calm someone down who's having a panic attack, is to coach their breathing. If they are receptive to that, that is going to be the best treatment for them. And once their breathing returns to normal, then your blood chemistry will start to return to normal, and most of these symptoms should start to dissipate. So a lot of times panic attacks are people that we can do a lot of good on scene, and our coach breathing will help them return back to normal, usually. All right, going into a little bit about depression. Depression is a serious mental disorder that can lead to suicidal thoughts and actions. A lot of people self-diagnose themselves with depression, so especially teenagers will say, oh, I'm very depressed, but they don't have an official diagnosis of it from a psychiatrist. So keep that in mind. That might not be an official diagnosis, but that in no way means that their feelings aren't valid, and they probably do have depression. Depression affects all age groups. We commonly start to see depression in adolescent patients. Typically, we aren't seeing these in young kids. It is starting to become a little bit more common in young kids, but typically we don't see this until adolescence, when you start having self-image problems. We're also seeing an alarming rise of depression in the elderly, and that's for many reasons. It could be for your own failing health, or all your friends and family have started to die off. Your career you've been retired from it, so your career's over, and you feel like you aren't producing anything for society anymore. There's a lot of different reasons that depression starts to affect the elderly, and the elderly, unfortunately, are more prone to take action on their depression. They're more prone to actually commit suicide from their depression. So this is a rising concern in the United States. It has been for quite a few years, and it is something that we have to take seriously. Typically, most depression is treated with home prescriptions, but this only happens if you actually get it diagnosed. Like I said, a lot of times depression is self-diagnosed, and if you self-diagnose, you can't self-prescribe meds. So a lot of depression has gone untreated just because people don't want to go to a doctor and actually get it diagnosed. Depression can oftentimes lead to suicidal parties. It's not the only cause of suicidal parties, so it can be caused by many different events or medical problems. Keep in mind that if a patient is suicidal or homicidal, they are unable to refuse care. So they fall under a specific mental health law, which we'll talk about in a second, but they are not allowed to refuse your care. You have to bring these patients to the hospital. Keep in mind that attempts or threats of attempts are treated the same way in the eyes of the law. So if they threaten to commit suicide or do something homicidal at any point, then they are not allowed to refuse care. Keep in mind that if you do have a suicidal party that has attempted suicide, make sure that you're treating that. That can manifest itself in some sort of poisoning or overdose or some sort of traumatic injury. So make sure that we're treating those sides as well as the behavioral side. Keep in mind that you do have to take any threat seriously. And I say this fully knowing that there are a lot of people out there that every single day they call 911 threatening suicide, and we bring them to the hospital. They get discharged 30 minutes later, and then they call 911 again threatening suicide, and this goes on for years and years and years. There are those types of people out there. But there's also plenty of people that really mean it when they make threats of suicide. And if you leave them alone, they will try to commit suicide. So you have to take every single threat very seriously. We cannot afford to risk to be wrong if we're guessing that someone is just joking about something. So, like I said, these patients do have to legally be transported. Sometimes they might not want to go, so they will be transported against their will. That's when we really should be involving law enforcement. Law enforcement can actually place them in their custody for up to 72 hours and force them to go to the hospital against their will because they are then in police custody. That is covered in the New York State Mental Health Law, Part 941. So you might hear that patient is 941. That means that they are in police custody for mental health reasons so that they can be evaluated at the hospital. So that is how we get the legal authority to transport patients against their will. Again, this comes from police. So the police have to put them in their custody, so we need to get police involved in order to use Part 941 of the mental health law. So suicide, in the last study I saw, suicide is the 8th leading cause of death. In the age group ranging from 15 to 24 years old, it's actually the 3rd leading cause of death in the United States. That is very alarming. So I like to say a lot of suicide is preventable if you have proper mental health care. I know that sometimes suicide seems unavoidable for a lot of patients, but we really need to get better mental health care for the general population to try to lower these numbers. 8th leading cause of death in the entire United States is very, very high. So keep that in mind, that there are plenty of people who do commit suicide, and that's why we have to take every threat very seriously. And if someone does commit suicide, it does affect hundreds, if not thousands, of people for every one suicide. So keep that in mind, that we do have to be empathetic and we do have to take all this stuff very seriously. I say that knowing that you guys are going to have long careers, and there are going to be patients that will wear down on you, because there are patients out there that just want to go to the hospital, so they say that they have suicidal ideations because they know that we have to bring them to the hospital if they say that. There are people out there that abuse the system. I get that. But there also are plenty of people out there that are not abusing the system. And so we can't take the chance and be wrong about thinking someone is abusing our system. Talking about bipolar disorder. Bipolar disorder, probably a lot of people have heard of before. It's a disorder that causes mood swings where you go from very low to very high. So we go from depressive lows all the way up to manic highs. We are usually involved as EMS providers in the manic high periods where they're kind of bouncing off the walls. So we will see both sides, but that's when people start seeing behavioral emergencies, is when they go to the manic high parts. Typically, bipolar disorder is well controlled with therapy and home prescriptions, but home prescriptions only work if the patient actually takes them. So if the patient's non-compliant with their medications, that's where we get a little bit more involved, usually with their care, because they have many more episodes of the manic highs. Again, we are called for the depressive lows sometimes, but it's usually the manic highs that people think that this person is having some sort of crisis, and they are. So that's when we usually get involved. Then talking about schizophrenia. Schizophrenia is a disorder that affects a person's ability to perceive reality accurately. So because they can't perceive reality accurately, they are very unpredictable. You don't know what they're perceiving, and you don't know how they're going to act next. So that can cause a lot of manic behavior, and this can also cause very combative behavior. They might not realize who you are or why you're there, and they might see you as a massive threat. So they can be very combative to you. They can be combative to someone that they are imagining. So these are very unpredictable patients, and a lot of times they don't understand what they're doing. You do have to keep that in mind, that people with behavioral emergencies, a lot of times if they're combative, they don't understand that they are being combative to us. So we have to still treat them with respect, which is hard to do when someone is swinging at you and trying to harm you. You have to understand that they are not in their right state at the moment, and they probably don't comprehend that they are doing this to us. So you still have to treat them with respect. Another danger with schizophrenia is they can have symptoms that suddenly appear out of nowhere. They can be completely fine for 20 minutes and then just completely have a break, and that causes a scene safety issue for us. So you always have to be on your guard for sudden changes in behavior with schizophrenic patients. So like I said, it's hard to differentiate between a behavioral emergency and a behavioral emergency caused by some sort of medical condition that's happening. And we're called for these medical conditions quite a bit. So if you think about things that could cause altered mentation, we've talked about most of these already in this class. You could have hypoglycemia, hypoxia, stroke, head trauma, taking some sort of poisoning substance that will alter your mind, and then being hypothermia or hyperthermia. All these can change a patient's behavior, so you have to rule all this stuff out before you can say, yeah, we think that this is a behavioral problem, because a lot of medical emergencies can mimic behavioral issues. So situational stress reactions, like I said at the start, stress is a big cause of some of our psychiatric emergencies. And that is, a stress reaction is a normal reaction to stressful situations. And so we normally produce emotions to react to our environment. That's normal. So having fear, grief, or anger, or any other emotion, that is a normal response. We're supposed to have these responses. It's just how we react to some of these responses that might create a behavioral emergency. I expect you to have some fear if you're being attacked. I expect you to have some anger if you're being attacked. It's just how you react to those emotions and how you compose yourself is what's going to determine how well behaved you are. So when we have patients with situational stress reactions, try not to rush anything. Let them know who you are and what your role is. A lot of times people just see us as a uniform, so they assume that we are police. So let them know that we are medical staff. We're here to make sure that they're okay medically. Always remain calm and keep your own emotions under control. This can be very hard, especially if a patient's trying to attack you. You have to keep your own emotions under control. If you can't do that, you can't help anyone else. Listen to the patient and be honest with them. We do not lie to our patients. So if the patient's having a hallucination, don't play along with their hallucination. Be honest with them. If you're to the point where you have to restrain the patient, don't lie to them and try to trick them. Be honest with them. Say, we have to restrain you now. So don't try to be manipulative of these patients. And as always, stay alert for changes in behavior. That causes a big scene safety problem with us. So acute psychosis is a severe break in the patient's abilities to process information and interact with their environments. We talked about this a little bit with schizophrenia. So typically someone who goes into acute psychosis has some sort of diagnosed disorder. So this typically is not your average Joe who has no history of psychiatric problems and then suddenly at age 40 has a break of acute psychosis. Typically, if that happens, that means there's some significant medical problem going on causing this altermentation, which then causes the acute psychosis. Typically, this is people who have diagnosed disorders that are experiencing this. So this is where we usually get involved, because these patients get out of control to where others around them cannot safely be there and the patient cannot safely be by themselves. So we get involved to mitigate this. Acute psychosis can lead into something that we call excited delirium. This is the far extreme end of a behavioral emergency. The patient will have intense confusion. They'll be incredibly combative. You probably heard people say that they have superhuman strength. That's true. I have had patients who've had excited delirium bend the metal part of my stretcher because they were restrained to my stretcher, and they pulled so hard that they bent metal with just their arms. That is not normal levels of human strength. So when someone gets to the point of excited delirium, they almost always need to be sedated medically in order to safely treat. So these are patients that we need to call ALS for, because ALS can sedate these patients so that we can safely treat and transport these patients. So this is something that you need to recognize, that you need to request ALS to deal with. All right, going into some emergency care for behavioral and psychiatric emergencies. So keep in mind that behavioral emergencies are very fluid. There's a wide range of presentations. They can go from very calm, pleasant, just need to go to the hospital, talk to someone about something that they've been thinking about, to the full-blown excited delirium. We have a complete range that covers all that. So you need to be very aware that this can take many different forms, and it can change forms in the middle of the call. Some things that you need to watch out for is if a patient is withdrawn, not communicating, or if they become agitated, or if they have bizarre or threatening behavior, or if they wish to harm you or themselves. Those are all red flags that we have to be very, very, very aware of what's going on. Again, a lot of patients confuse us with law enforcement, so one of the first things you want to do is identify yourself and why you're there. Say that you are Mike, you're a paramedic with the ambulance, you're trying to assess them medically. Make sure that they know that you are not law enforcement. They might not understand that. You might have to repeat it a few times and they still might not understand that. They might still think you're law enforcement, but try to keep on identifying yourself and your role. Speak very slowly and clearly and try to make eye contact with them. Try to use your therapeutic communication skills that we've talked about before. You should always be listening to the patient. Try not to judge the patient. They can usually tell when you're judging them. Use open, positive body language and acknowledge the patient's feelings. Don't try to dismiss them. Acknowledge that they have feelings. The feelings are valid. So again, one of our biggest things we need to keep in mind is our own personal safety. So try not to enter the patient's personal space. Usually a 3-foot zone is okay. If the patient's on a stretcher, I like to be in the captain's chair behind them. That makes it very hard for them to turn around and attack me without a good amount of warning. They usually have to unbuckle, stand up, come around, and then they have access to me. By then, I'm prepared to react to that. You have to be very alert for changes in emotional status. They can swing very quickly, especially if they have a psychiatric disorder that causes very quick swings. And you might need to restrain the patient, which we'll talk about in a little bit. So we just covered most of this for our patient's assessment. Make sure your ABCs are intact. Make sure that you're continually doing your scene size up and reassessing your safety. A lot of the signs and symptoms that we might be seeing are panic or anxiety, an unusual appearance, disordered clothing, poor hygiene, agitated or unusual activity, unusual speech patterns, bizarre behavior or thought patterns, suicidal or self-destructive behavior, or being aggressive towards us. So we've kind of covered all this stuff before, but these are some of the common signs and symptoms that we're going to be seeing. So make sure that you treat any life-threatening problems and you think about any medical or traumatic reason that might be causing this behavior. Again, we always treat to the worst possible case scenario. So you have to rule all that stuff out first. Spend a good amount of time talking to a patient. Try to de-escalate things verbally with a patient. Encourage them to talk back to you, to tell you how they're feeling. Again, if they're having hallucinations, do not play along with those hallucinations. I know it can be very tempting to do that, but we are not supposed to play along with these. We are not supposed to encourage them in their hallucination. If they do have family or friends, you can try to have them come in and help communicate with the patient, especially if they're being very hesitant towards you. Try to have a family member or friend be kind of a buffer between you guys so that they will start to communicate somehow. So it is very important that we don't argue with these patients. It's very easy to want to argue with these patients, and we shouldn't be threatening or indicating using force. If we have to use force, that's not a thing that you dangle in front of me like, oh, if you don't behave, I'm going to have to restrain you. It's you need to use force or you don't need to use force. We are not threatening them with this. It's yes, this patient is at a point where they need to be restrained, or no, they are not. If you do use force, it's imperative that you notify the receiving facility that you're coming in with a combative patient, one that's so combative that you had to restrain them. So keep that in mind. So there's a 23-year-old male patient. His girlfriend called 911 after a domestic dispute. He's uncooperative and refusing treatment. The girlfriend reports the patient is depressed and suicidal. He owns a gun and has threatened to shoot himself. Can you treat the patient if he did not call? Should you believe the girlfriend? Does the patient need treatment or transport? Can you treat and transport the patient against his will? What should you do? This type of call really should involve police. It should involve police from the start because it was a domestic dispute. So to ensure your scene safety, they should be there to make sure that there's no violent outburst that happens. So in this case, the only way that we can treat or transport the patient, since he's unwilling, is under the mental health law 941. That, again, is something that only a police officer can enact. So let the police officer make his own determination about if these threats are credible or if the girlfriend's just trying to get the boyfriend in trouble and he never actually made these threats. So that's where we kind of pawn it off to police and let them decide what they want to do with it, because they're ultimately the ones responsible for taking the patient into custody and transforming against his will if that's what they decide is needed. That is a police thing to decide, not an EMT thing to decide. So involve them immediately and let them make these decisions. So a lot of times our aggressive or hostile patients, we usually have an idea before we even enter the scene, whether it's from dispatch or police on scene already, or we have family or bystanders on scene. They will usually tell us that this patient is out of control or this patient's very aggressive or combative. So usually we have an idea, but that's not always. Some patients that you think are very calm will change immediately. So you always have to make sure that you know what your escape route is on every single call, not just behavioral emergencies, but on every single call. You need to know how you're getting out of that house if you need to in a very quick way. With that being said, whenever you bring your equipment in, always put your equipment not in the way of your escape route. A lot of people will drop their bags at the door and then go treat the patient. You do not want your bags to become a tripping hazard for you. So put them to the side of you or put them between you and the patient. You always want a very clear path out in case if the patient becomes suddenly violent. If they do and you're carrying the bags on your shoulder, drop them right away and go. We can replace the bags, we can replace the equipment, we can't replace you. So again, do not threaten patients. If you have to go hands-on with a patient, it's a matter of fact or no. It's not something that we threaten to do. We either have to do it or we don't have to do it. And then stay alert for weapons of any type. Anything can be turned into a weapon. It's not just the obvious gun or the knife sitting by the patient. It can be some sort of blunt object, like a stapler or a screwdriver or just a book swung hard enough. So be alert for anything that could be utilized as a weapon. So if we do have to go hands-on with the patient, there's a term called reasonable force. And reasonable force is the amount of force that is just necessary to keep the patient from injuring themselves or others. So that changes per patient and per situation. So some things that we need to keep in mind is how big the patient is, how strong they are, what type of behavior are they exuding, are they aware that they are coming after you and are they trying to physically hurt you, or are they just having a psychotic break and they are not aware of what they're doing, they're just kind of swinging their arms around without trying to hit anyone. So find out what type of behavior it is, what their current mental status is, and then what type of methods of restraint you have. We should have soft restraints on the ambulance as something that's mandated to carry, but sometimes someone or a police officer might want the patient to be in handcuffs, which we're going to be talking about that in a second. So it does say never to attempt restraint without proper legal authority and sufficient assistance. That is true. We should always call for police if we're restraining someone. But I don't want you just standing there getting beaten up by a patient because, oh, police aren't here yet, so we can't go hands-on on the patient. We just have to stand here and take it until police come. You know, if you need to restrain the patient immediately, restrain the patient, just call for police to come get to you as soon as they can. So use your situational judgment. There are many different forms of restraints. We cover these in class in person, so if you want to go over these again, feel free to see me. But the number one thing behind any sort of restraint is they need to be capable of immediate release. That is, in all caps, in all bold type in our protocols, that restraints must be capable of immediate release. Sometimes that's, if you have a soft restraint, it means that you can just cut the restraint immediately. If you cut the restraint with your scissors that you carry with you, that is an immediate release. So they do make commercial restraints out there. That's what officially I'm telling you is what you should use. In my personal experience, I found that the commercial restraints fail quite a bit, especially with patients who are very aggressive. So I find a slip knot with a triangular bandage works a little bit better. Again, I can show you in person how to do this. And as long as I can cut that triangular bandage, it is capable of immediate release. When you're applying restraints, you can try to use some pressure areas while applying the restraints. So, for example, if you're restraining the legs down, put your knee just above the patient's knee, and that's going to trigger a little bit of pressure point to where they can't come up and kick you with that knee. It kind of renders the legs somewhat ineffective, which allows you to tie them down. So again, we really want to try to have law enforcement available and have law enforcement actually do this instead of us. But there are cases where you might need to do this before law enforcement gets on scene just to assure your own scene safety. So use your own situational judgment. And again, if you need to go over how to apply restraints, feel free to see me and we can go over it again. When you have especially patients that don't perceive reality well, so it could be our dementia patients, our Alzheimer's patients, sometimes our schizophrenic patients, they might want to take their seatbelts off when they're on the stretcher. Sometimes this is why they get restrained, is they keep on taking their seatbelts off and trying to get off the stretcher. Usually this is where we have some lighter restraints, just because we just need to keep their hands away from the seatbelts. Something else you can do that's before restraints is flip the seatbelt buttons around so the little thing that you push is harder to access. Even just that simple flipping it around might deter someone who's having some sort of altered perception of reality. They won't be able to take it off easily, so they move on. The police, like I said earlier, might want the patient handcuffed. If they are handcuffed, which the police do have the right to request that, they must be handcuffed to the stretcher because police are used to having patients handcuffed behind their back, but we need to be able to access their arms. So you have to handcuff each wrist to the stretcher, one on either side, so that we can fully access our patient. And then you need to have the police officer ride in the back of the ambulance with you, because restraints, which handcuffs are restraints, must be capable of immediate release, which means you need the handcuff key with you in the back of the ambulance to immediately release the handcuffs if needed. So if the police insist that the patient has to be handcuffed, They are riding in the back with you to the hospital. When a patient is restrained, you are responsible for making sure that they have a patent airway. You need to be responsible that the patient is adequately secured throughout transport. If they start to spit, go ahead and put a surgical mask on them. I've seen a lot of very inappropriate things done in my career for people who are spitting, one of which is putting a non-rebreather mask on a patient with no oxygen flowing, and I've seen someone actually duct tape a non-rebreather mask to someone's face. That's inappropriate. So put a surgical mask, and that should deter most patients from spitting. Always reassess restrained patients frequently and undo the restraints if they start to deteriorate, and document everything you do thoroughly. Restraints are not a everyday thing that we do. Restraints are something that's a significant event, and you need to have good reason to do it and then document that reason behind it. You are taking away someone's ability to be free. That's something that is not taken lightly in this country. We need to have good legal reason why we're doing it. Keep in mind that not all hospitals can treat behavioral emergencies, so know the hospitals in your area. For example, in the Syracuse area, Crouse cannot take care of behavioral emergencies. Every other hospital in the Syracuse area can, but Crouse can't. So know the capabilities of your hospitals. I know I've said this to you guys dozens of times, but I'll keep on saying it. You have to know where you work, and you have to know the appropriate facilities for the area that you work. Remember that the two biggest areas of litigation with EMS are refusals and restraints. If you restrain someone who didn't meet criteria to be restrained, that is a very big area where we can find ourselves in legal trouble. Typically, laws protect us to transport patients that need it against their will, but you need to follow those laws. You can't just willy-nilly restrain someone because you think they need to go to the hospital. You need to have legal reason to be able to do that, such as being suicidal, homicidal, or having altered mentation where they can't refuse their own care. Keep in mind that sexual misconduct allegations are rampant among patients, and unfortunately there have been some that have been found to be true, but the vast majority of them are not. So whenever possible, have a same-sex provider be in the back with the patient. So if you have a female patient, try to have a female provider in the back. I know that's not sometimes practical in some areas, but try your best to do that. That will help restrict our ability, or our patient's ability, to accuse us of sexual misconduct. When possible, have a third-party witness the transport at all times, so having a family member ride in if that's appropriate. That way you have a witness to events. Fortunately, technology has advanced these days to where a lot of our ambulances have passageways between the front and the back, and you also have a camera in the back for the driver to be able to see what's happening in the back. So technology has helped us significantly to be able to dispel any false allegations, because you can see what's going on in the back. In the olden days, that was a little bit harder to do. Also, our windows are typically transparent, so someone driving behind us should be able to see into the ambulance. So if you have law enforcement driving behind you, they should be able to see in the ambulance, and they would see an event transpire typically. So the biggest thing is try to be beyond reproach. Have as many safeguards as possible. Sit in the captain's chair where you are within view of your partner. Be able to have your partner be able to hear back, so they can hear the conversation, and they would hear if you stood up or if there was something going on with the patient. So take steps to be beyond reproach. All right, so going into a little bit of chapter review. So as an EMT, you will respond to many behavioral emergencies. Be sure to ensure your own safety before entering a scene or caring for a violent or potentially violent patient. A considerable portion of the population has a diagnosable psychiatric condition. However, not all patients are violent. It is important to remember that patients in crisis are patients and people who need your compassion as well as your care. Always consider patients acting in an unusual or bizarre fashion to be experiencing an altered mental status. This will help you avoid overlooking a medical or traumatic cause for the patient's problem. Because treatment of these patients usually requires long-term management, little medical intervention can be done in the acute situation. However, the way you interact with the patient during an emergency and assess your patient throughout the call is crucial for their continued well-being. Remember, safety is the first priority when approaching a patient with altered mental status. Remember, psychiatric and behavioral emergencies are prevalent in our society. EMTs should treat them as they would any other potentially life-threatening disorder. Remember, assessment of altered mental status should rule out physical causes first. Remember, psychiatric and behavioral emergencies can present differently depending on the disorder. There are best practices EMTs employ in approaching, assessing, and treating such patients. Remember to follow local protocols and use appropriate procedures to restrain patients when necessary. So you should know what methods help calm the patient suffering from a behavioral or psychiatric emergency at this point. You should know what you can do when seeing size up reveals it's too dangerous to approach the patient. You should know which factors help assess a patient's risk for suicide. You respond to an intoxicated minor who is physically aggressive, threatens suicide, and whose parents permit you to treat but not transport the patient. How would you manage this patient? So this is a patient that should have police be called to manage because this patient has to be transported to the hospital. They are threatening suicide, so they fall under New York State 941 law. So this is someone that will have to be taken into custody of the police because the parents are not permitting transport. So the patient will have to go into custody and be transported against the parents' will. So again, this is where we need to involve law enforcement very early and have them be able to take the patient into custody so that we can do our job effectively. That brings us to the end of this chapter. I know this is pretty brief, especially with how much goes into behavioral emergencies. So again, I highly recommend that you go ahead and do some more research on your own. And a lot of this stuff will come with some experience, but really we need more overall training on how to handle behavioral emergencies than just a quick 45-minute chapter about it. This is something that EMS is lacking in a little bit, and it's starting to really show, and this is something that we should be changing in the future and including a lot more education on behavioral emergencies for EMS providers. So until next time.